then you're good to go. I guess at this point everybody knows me, but I'm Shada. I'll present my lecture on environmental injuries. There's a lot of different environmental injuries that you would encounter in critical care and emergency setting. I decided to focus on a couple here, and we'll get started. I do want to thank Dr. Kinney. He's the one who provided me with a lot of resources for this topic. Okay, so our learning objectives for this lecture is actually to focus on the physiological effects of accidental hypothermia. That's one of the environmental injuries we're going to talk about. Management of accidental hypothermia, mechanism of injury from electrical shocks and lightning injuries, management of these injuries, and then just a brief overview of inhalation injuries, because Jess's talk did talk about burns and some smoke inhalation injury in her lecture. So I'm going to focus on the other two and just go briefly over the inhalation injuries. Okay, so can somebody read this case?
On initial evaluation, he appears disheveled and is unresponsive. He appears to be breathing slowly. His pale appearance and his mood looking cold. What's your top priority when first evaluating?
So say you are the passerby, you're a palm crit fellow.
Time to get right. I guess my usual, like your ABC, right? Like once they always tell you, like, make sure your environment is safe.
Yeah.
Once the environment is safe, like the ABCs would be the first.
Yeah. So don't forget the basics. No matter what your initial, and you'll see this theme throughout this lecture, where no matter what the injury is, your initial evaluation and focus should be on your basics. Airway, breathing, circulation. And then you can, once the patient is a little bit more stable or stabilized, then you can start figuring out what's going on and do injury-specific managements. Okay, so $57.65. Oh, 50. Okay. Thank you, Mike. Okay. Okay. So when you see this patient, what's your primary concern? Just given the basic presentation here, your primary concern is what? Hypothermia, right? So once you've done you've assessed airway, breathing, circulation, you've done your initial management, okay. So accidental hypothermia, so there's a difference, right? We do encounter therapeutic hypothermia in the ER when we, post-arrest, targeted temperature management. This is accidental hypothermia. So the definition for accidental hypothermia is unintentional drop in core body temperature. So that's the key word. It's the core body temperature below 35 degrees Celsius. Now, there are certain risk factors that puts patients at slightly higher risk for developing hypothermia. And this includes extremes of ages, right? So you have your elderly patients and at the either extreme, right? So you have the pediatric population and you have your elderly patients. And for different reasons, right? The pediatric patients, they can't, especially infants, they don't have shivering or those responses. So it's hard for them to create heat and energy. And so because of that, they're high risk. And then for elderly, it's because of, reduced cardiac output, other comorbidities. Alcohol drug use is another factor, risk factor for development of hypothermia. Homelessness, it's pretty self-explanatory, right? Psychiatric illnesses, certain endocrine disorders, especially thyroid-related issues, hypothalamic issues, adrenal issues. And then obviously, low temperatures during winter season. However, you do want to remember that you don't need frigid temperatures for patients to develop, or for you to encounter patients with hypothermia, right? It could be fall and people can still develop hypothermia, because essentially all it takes is for the body temperature to drop below 35. So what are some of the mechanisms of heat loss when you encounter hypothermia? So and essentially this goes back to your physics lecture in undergrad. So the mechanisms of heat loss are usually convection, radiation, conduction, and then evaporation and respiration. So convection is essentially where the body heat is lost to the ambient air. And essentially warm air rises up, cooler air surrounds it, absorbs the heat, rises up. So that's how you're losing heat. Evaporation is essentially when people sweat, because the body's at higher temperature, they sweat, and then it changes from liquid to vapor form. Conduction is through direct touch. So essentially when say a homeless person who in the middle of winter is sleeping on the sidewalk, the body's losing that heat with direct contact with that sidewalk. So that's conduction, that's direct contact. Radiation is where the body heat is lost to nearby objects without physically touching it. And then respiration is you're actually breathing out warm air. And so these are the mechanisms by which the body loses heat. Now, what's the initial response to cold temperatures? Shivering, right? So, and why do humans shiver in cold temperatures? Right, so they're essentially to generate heat, right? Now that only works as far as you have good cardiac output and you have good glycogen storage. So shivering, you'll see it. It's a good response to create heat, to protect you from the deleterious effects of the hypothermia. But you do have to remember that only works if the patient has good reserve, good glycogen stores, so because they'll be burning a lot of energy to create that heat. Now, however, when at certain temperatures, when the temperatures drop below certain levels, shivering doesn't happen. It's not efficient. So people actually stop shivering after the temperature drops below a certain threshold. Okay, so what are some of so we talked about shivering. Usually you see that in the first 6 hours, and it usually becomes ineffective below 32 degrees Celsius. So if the body temperature is at 31 or lower, usually you won't find these patients shivering, because it's not effective at that point. Their capability of generating heat versus the ambient temperature, it doesn't keep up with that heat loss. So the shivering it's not effective. What else can you see with hypothermia, accidental hypothermia? Cardiac arrhythmias, yeah. What else? What happens to the extremities when, yeah, so you have peripheral vasoconstriction, yeah. So initially you'll see peripheral vasoconstriction. And essentially what your body is trying to do is essentially divert all the blood supply to the internal organs and vital organs. So you have, blood diverted to the core of your body. So somebody said cardiac arrhythmia, so tachycardia, peripheral vasoconstriction. A lot of these patients, when when we see them in the ICU too, or in the ER, when they come, they were found by the road and they were brought in. Altered mental status, or just altered sensorium in general, is usually the first subtle sign for hypothermia. Does anybody know what cold-induced diuresis is, or why that happens? I hear mumble. Everybody's looking around. Okay. So essentially, it's just a way of your body, just a way that your body preserves heat when the temperatures start to drop. So essentially, what happens is, like I said, when the ambient temperatures are pretty low, your body you have peripheral vasoconstriction, so all the blood starts getting diverted to the core, to the internal organs, right? Now, what that means is there's increased blood return to the heart as well. So to prevent fluid overload from happening, your kidneys actually start dumping a lot of this free water, and it's not effective diuresis. Actually, it's just losing free water to keep up with that fluid overload. So that's called diuresis. So essentially, with all these changes happening, few other things. So with cold temperatures, obviously your muscles get stiffer, and that includes your respiratory muscles too. So you get a stiff chest wall, your work of breathing goes up, hyperventilation ensues, arrhythmias. And then one thing to remember is with arrhythmias, especially with like critical hypothermia, these patients that are hypothermic, especially the ones that are moderate to severe hypothermia, you want to be very careful because they're prone to even like positioning. Their myocardium is very sensitive. So even when you position them in the state of this critical hypothermia, be careful because even minor movements can predispose them to arrhythmias. And then there's actually a phenomenon called paradoxical undressing that actually occurs. I didn't know about this till, and there's only like case reports and like some case series that have described this phenomenon. Nobody knows exactly what causes this, but when there's critical hypothermia, so core body temperature below 28 degrees Celsius, a lot of these patients, they'll find them naked, and it's essentially the hypothesis is that there's change in it goes from peripheral vasoconstriction to vasodilation, and they start feeling this heat. And so they start like taking their clothes off, and because even though nothing has changed in the environment, the temperature is still low. So nobody knows the exact mechanism, but this is a phenomenon that has been described in case reports and case series. Okay, so there's actually a staging system for the severity of hypothermia. It's called the Swiss staging system. So essentially going from stage 1 to stage 4. Stage 4 is essentially dead, close to dead, right? There's no vital signs. Stage 1 is and it has to do with their clinical findings and the core body temperature. So clinical findings for stage 1 hypothermia is when they're still conscious, they're shivering. So they're still within that initial state of hypothermia. The core body temperature is anywhere between 32 to 35. And we'll talk about therapy a little bit later, but let's just focus on the clinical findings and the core temperature. The stage 2 hypothermia is where you now start developing altered mental status. You have impaired consciousness. They stop shivering at this point. So, and the core body temperature is usually 28 to 32. And then stage 3 is where they're unconscious, but vital. You can still, they still have a heartbeat. They still have, you can still measure their respiratory rate, even though it's pretty, low, but they still have vital signs present. And this is usually when the core body temperature is between 24 to 28. And then stage 4 is where essentially you have no vital signs. It's critical hypothermia. And essentially at this point, you're either, resuscitating the patient, following your ACLS protocol, actively rewarming the patient. One thing to keep in mind is when you have these patients and say they have cardiac arrest and you're trying to resuscitate them, a lot of times we tend to, we've done resuscitation for like 20 minutes, let's just stop, let's just call it. Don't do that for hypothermic patients. You can't declare death unless temperature is above 35 degrees Celsius. So if they're 32, you can't call them dead. So essentially you have to keep going till you can get their body temperature above, with whatever interventions you're going to do before you say, oh, I'm going to call this patient dead at this point. So that's one thing to keep in mind. Okay, so our 72-year-old patient that I initially presented that was found in the parking lot was found to have a core body temperature of 31 degrees Celsius. So what level of hypothermia, just based on the core body temperature, where would this fall? Stage 2, right? So 32 to 35 is stage 1. Stage 2 would be 28 to 32, right? So stage 2. Would you expect this patient to be shivering? No. Good. So if you were to do an EKG and if you were to see some changes that would make you, so say you didn't know what the background story was, is a Jane Doe, or if it's a female Jane Doe comes in, you did the EKG, what would you expect to find? Okay, so bradycardia. So initial stages, you might actually see tachycardia, but yeah, you can see bradycardia. What else? Prolonged QTC. J waves, yeah. So there's no ideal, like usually with rewarming, it goes away, but you at 31, like mild to moderate, you sometimes still see the J waves. What's the other name? Osborne waves. Yep. So this is what they look like. So essentially, make sure you remember it's J point and J waves are two different things. So J point is where your SD segment starts and your QRS ends. J wave is that Osborne wave. So it's that little blip that you see right after your after the end of the QRS. Now it's likely due to early repolarization or delayed depolarization secondary to the hypothermia. That's what causes this Osborne waves. When you see this, you want to think of hypothermia, but they're not pathognomonic. So keep that in mind. If you see it, you should have a high suspicion, but they're not pathognomonic. So you got the EKG, you have the vitals. I didn't tell you, but say for this patient who was unresponsive, you did the ABC, what are some of the labs or imaging that you would order for this patient? Would you order anything? Electrolytes, okay. Thyroid, yeah. What else? So this patient that was found in the parking lot, what else are you looking for? Draw, yeah. So yeah, tox screen. Anything else? Alcohol level, yeah. Sorry. ABG, yeah. What's the thing you want to keep in mind when you order the ABG on these patients? Yeah, so you have to correct it for the temperature, right? So those are, when you get those ABG with core body temperature that low, may not be truly reflected because your oxygen dissociation curve shifts, right? So you have to keep that in mind when you interpret these ABGs. So ABGs, your electrolyte panel. The other big thing you want to check for in these patients is the coagulation panel, right? Because with every time you have temperature issues, be it hypothermia, the proteins will denature, right? So you can have issues with coagulation. So make sure you check a coagulation panel, especially somebody who's found down, you don't know what happened. They might be bleeding internally, especially with the stress of the hypothermia, things, they might be bleeding internally, you may not know. So make sure you check a coagulation panel, amylase, lipase, and then endocrine markers such as TSH, cortisol, toxicology screen. And then obviously if you're suspecting some kind of trauma or depending on the patient's presentation, you might want to get appropriate imaging. So you get the appropriate labs. How are you going to monitor this patient's temperature? Huh? Yeah, so you can do I heard temp Foley. What else? Esophageal, yeah. What else? Rectal temperature, yeah. So a lot of the data for these different measurements or devices for measurement is actually in the setting of therapeutic hypothermia. However, when you have accidental hypothermia, you don't know what's going on, right? So problem with the bladder temp Foley is, what if they're dehydrated, if their core body temperature is it's reflective of that fluid in the bladder, right? So if they've been out there for hours, that urine is probably pretty cold too at this point. So that's one. Same thing with the rectal temperatures. You want as central as possible, right? So that's how you want to think about it. You want to get as central a temperature as possible. And what's the ones that you described, which is the one that would give you the most central? Esophageal. And actually in gold standard, some people would say, pulmonary artery temperature is if you have a swan, that's what please don't put a swan in just to check the temperature. But if they have one, if they somehow got one in the ER, but that should not be a go-to. So you would do the esophageal probe would probably be the closest, because you're right next to the heart, right? You're right next to the left atrium. It gives you the core body temperature. So don't do the axillary temperatures. They're not, I would say, not even hypothermia in general. It's not recommended for most of. Yeah.
This adds to bladder. To your point, though, there is some, even though we do it a lot, but if you're annular, right, the idea you need volume in the bladder to be accurate. So many of these patients are cardiographs do come fully, but they're annular, like that may not be an accurate temperature. So keep that in mind. We do, but just keep that in mind. For annular, further polyurethra, your temp fully may not be accurate.
Yep. So Dr. Kinney actually re-emphasized that patients that have like post-arrest or in the setting of accidental hypothermia, you want to, you want to take temp Foley with a grain of salt, because if they're anuric or oliguric, it may not be truly reflective of the core body temperature in these patients. Okay, so you did the initial ABC, you got the labs, you got the imaging. What's the next step? So say in a different setting, so say this patient is just coming to the ER, you're admitting directly from the ER, you go down, go see the patient. He's not intubated, he's just rolling in. The parking lot was just outside and he's just rolling in. So airway, breathing, circulation. So if they're unresponsive, obviously, you're going to do the initial airway, breathing, circulation. With breathing, make the things you want to start thinking about is once you've established, circulation, breathing. With breathing, you can essentially, with all these interventions, you can start warming up the patients a little bit. So you can, with the mechanical ventilation or high flow, whatever you use on these patients, you can actually warm up the air. So you can humidify and warm the air in these through the mechanical ventilator or the other oxygen devices. For when you're giving them fluids and they're really hypotensive, consider warming up the fluids a little bit. Usually they'll have up to 42 degrees, 40 to 42 degrees. You can warm the fluids and then administer the fluids. But I'll talk about when you would consider active rewarming. And then one thing you want to keep in mind is these patients are hypotensive and they come to you and, they need pressors. You're going to put a central line. Be careful with that guide wire, because if it goes close to the ventricle, like I said, these patients have a very sensitive myocardium. So even minor movements, even, just that guide wire touching the myocardium can put them into these, into VFib, into all these malignant arrhythmias. So be careful when you line these patients up. And then obviously, this is obviously removing the environment. So when you see them in the hospital, that's probably not an issue at this point. But if the patients are covered in, say, wet clothes or something, that's one other way they would be losing heat, right? Because that water on their body is going to absorb all the heat, so they're going to have more heat loss. So you want to keep these patients dry. So you're trying to minimize heat loss in these patients. Okay, so coming to the core, so how would you rewarm these patients? for mild hypothermia, usually what's recommended is passive warming. So this is where you would put a bear hugger or warming blankets, and you warm them at 0.5 degree to about 2 degrees Celsius an hour. That's how fast you'll be warming them up. Usually you don't need active rewarming in cases of mild hypothermia. However, once you start seeing temperatures below 32, that's moderate to severe, that's when you start thinking about, you'll be putting the bear hugger and the passive interventions, but you also actively rewarming these patients. Now with active rewarming, there are certain indications. So things that you look for where you would consider active rewarming is if they have cardiovascular instability. So if they're having frequent ventricular VFib or malignant arrhythmias, if they're hypotensive, temperature below 32 degrees Celsius, if they have endocrine insufficiency. These are some of the indications where you would consider actively rewarming these patients. When you're and we'll talk about how do we actively rewarm the patients, but when you're actively rewarming these patients, you also want to be careful if you're going to put like heating pads and things like that, where you don't inflict burns. So again, you want to make sure the interventions you're doing, you're reassessing, because sometimes we put heating pads on all of the, and we are actively rewarming the patient, and we forget to reassess the site where that heating pad was placed. So you want to avoid burns too, so you frequently reassess them. You always start rewarming at the trunk first. Why? Yeah, so all the distal vasodilation has caused all that rapid return of cold blood to the heart, right? So this can actually cause the core temperature to drop. It's called the after drop. So if you start, warming the extremities, they'll start vasodilating. So because of that, the peripheral blood is all warmed up, the central is still cold, and this causes the core temperature to drop further a little bit before it starts warming up. So it's called the after drop. So in order to avoid that, you would heat up the core first. And then if you're using warmed IV fluids as a measure of active rewarming, then usually we warm them up to 40 to 42 degrees Celsius before administration.
How do you warm up the IV fluid?
Good question.
If I needed it here.
I'm
just wondering how.
So that's the temperature of the fluid that goes through the through those pads. Yeah, there's a warmer. Yeah, I think there's a warmer, but I've seen it for a pediatric population. Yeah. Yeah.
Put any kind of IV fluid through. So it has sort of like heating coil, so as you run the fluid through it, it warms it up. I don't know how well you can regulate the temperature of the fluid as it goes through the warmer and how hot you can get it. Yeah. But it certainly will be much warmer than just ambient. Yes.
Yeah, so that when I was reading it, like that's what it showed for like pediatric population. Yeah. Okay, so active rewarming. So there's actually two types of active rewarming. So which is essentially active external rewarming, which is your bear hugger applying heat directly to the body, and then active core rewarming. So when you think about active core rewarming, that's where you think about warm air that you administer the patient, warm fluids that you're going to give the patient. And in certain scenarios and certain cases of refractory hypothermia, I actually saw videos where they actually put chest tubes, and they had warm fluids, like essentially flushing the chest tube, constantly irrigating the chest tube with warm fluids to warm up the core. So they would put 2 chest tubes, and then there's just like warm fluid running through it. There are other, you can do ECMO and veno-venous ECMO circuits. You can actually warm up the blood there. And then there are certain endovascular devices that you can use. I think we use it for like hypothermia and to induce hypothermia at West Bloomfield. I think that's what they use, like the catheters to do hypothermia. when I was looking at, I've not been to West Bloom, so I don't know what the device looks like, but essentially it looks similar. You have a triple, actually a central line, and there's like a flushing. There's a lumen going in and lumen coming out. So essentially, you're just doing hot fluids through the. These are endovascular devices where you just go.
Are there studies that show, because all that sounds, some of that sounds very invasive, are there studies that show that that's some benefit?
I didn't come. No, these are just things. They said it all depends on. There's no one thing is better than the other. Whatever is available, it's resource dependent. A lot of the institutions don't have these resources, so whatever is available. I didn't come across any like head-to-head study about, oh, this one's better than, because a lot of the centers won't have a lot of these devices. So I think so, yeah, because I know I'd heard at like West Bloomfield, but I wasn't sure, but it seems like we do, and we, CI, yeah.
Yeah, it has a, there are a couple of brand names of the devices. Probably the most common one you hear about is the LCS catheter. That's probably the most common. And you just have to know where you're going to place it, because your catheter lengths are different from the RJ versus the femoral. So you can't, they're not interchangeable. But those are the devices that we have.
I put a few with it once.
Yeah, of course you did.
But yeah, they're like this long. They're like
Yeah,
always hold down.
yeah.
They ran out of them.
Hmm.
They ran out of those catheters since he was there.
I'm not surprised.
Is that the same that they're competitors?
No, they're bigger lumen. Yeah,
So there's 5 ports that go tunnel.
yeah, yeah.
Is that the same that their competitor, buying from them now? He thinks it's called Airway. Because it's Celsius, it's like.
Yeah.
Oh my God. Okay, moving on. So you've tried all that, nothing has worked. We are at an institution where we do have ECMO and cardiopulmonary bypass capabilities. So think about this. But usually you would consider this when we think about it, critical hypothermia, meaning core body temperature less than 28, they have cardiac instability going into VFib, refractory VFib. These are the times when you want to think about ECMO and cardiopulmonary bypass. You want to try out all other interventions before you start putting patients on ECMO for when we barely have enough for our.
have to be very selective on what type of patient you
Yeah.
do the echo on, just for active.
It's like practically talking about like which one, because I mean, putting in like it would have to be like a surgical chest tube if they're going in and they don't have like peritoneal one. That sounds like something general surgery might put in. Like I can't see us using these. Like I don't know.
No, so that's why it's like center specific. If you're in like, area where there's a lot of like tourism with like mountains around, a lot of, patients that like the base, like I know when I was like looking this up, like base camp of Himalayas and things like that, like there's a lot of the hospitals that have like some of these capabilities. Patients come in with like accidental hypothermia and things like that. So some of them have these capabilities, but it's center specific. Realistically, here, I don't see us doing this. You're right. Like you would try everything else and, try to get the temperature down. But yeah, I've never seen somebody put like chest tube in just to do irrigation for like hypothermia. But
Like the same thing with the Foley, because they do continuous bladder irrigation. For others.
you can, but it's, yeah, the fluid shifts might, and then these patients already are coming in with AKI and things like that, and now you're, yeah, so you can do hemodialysis and heat up so any circuit that will warm up the blood going through it, you can use that to warm the patients up. So you have a lot of these different measures. I'm just throwing it out there because who knows where we might end up, so.
Yeah, and I think the key is whatever institution you're at, whatever people are most familiar with is the thing to do. So it may be that a dialysis circuit is the easiest and the most convenient way to kind of do this, depending on where you are. There are other places where trying to get somebody dialyzed in ICU is going to be really prohibitive and really difficult. So it's really about whatever your practice environment does and does relatively frequently. But it's important to know what alternatives you have just in case there's something you may not have done.
Okay, so just to recap, so we talked about mild, moderate, so the severity based on the temperature and the symptoms, the core body temperature. We talked about the severity of hypothermia, the usual neurological presentation. Remember, when you start having moderate to severe, you stop shivering. You don't see shivering in these patients. And then initially for cardiac, you might initially see tachycardia and hypertension. That's that initial response. And then once the temperature drops below, then you start seeing bradycardia, everything slows down, right? So sometimes you might get AFib, which is interesting in these situations, but that's just because of the sensitivity of the myocardium, and which makes it like prone to arrhythmias. And then you start thinking about active rewarming. Once you go below 32, start thinking about active rewarming at that point. Okay. So yeah.
I don't know if I saw it for rewarming. I don't know if I saw it on the side. You could like technically do what we use for like to reduce hypothermia.
Yeah, you can. Yeah, so that's surface rewarming, right? So you can do, be it bear hugger, be it Arctic Sun, you can use but anything that's active surface rewarming. And then if that doesn't work, then you might want to start thinking, use like active core rewarming then. Yeah. Okay, do you want to read this question?
44-year-old male was brought to the hospital after a witness cardiac arrest. He was building a machine with his daughter that could create an electric spark. He was in a systole on presentation to PR. You suspect that his cardiac arrest is likely secondary to the device. What is your next step in
Yeah, so you would do, again, the theme is ACLS, ABCs, these are the things you want to think about first. No matter what they're coming in for, your initial risk evaluation for these patients would be your basic, airway, breathing, circulation. So just going back to the physics again. Yeah. I thought I had to put, so it makes sense when you, it makes sense physiologically, right? So Ohm's law, I know it's been a while since we've done physics, but the amount of current going through a circuit is directly proportional to the voltage of the current and inversely proportional to the resistance, right? And then Joule's law, essentially that's energy. The energy that you create in an electrical circuit essentially is equal to the current square multiplied by resistance and voltage. So if you look at the energy that's created, that would correlate with how much damage you can have from that electrical shock, right? So if you look at all the variables, it makes sense that the extent of the damage from electrical injury or lightning injury is based on what the voltage is in the circuit, what the current amperes are on the circuit, how long was the contact, the duration of the contact, the type of current that's flowing through the circuit, whether it's AC, DC, alternating, direct, right? And then the path of the current flow, whether it's going head to toe, side by side, it's going hand to hand. So it depends on which way the circuit is flowing. And then resistance to tissues. The body tissue will create some resistance when when a patient gets an electrical shock, your body has its own inherent resistance. So that will contribute to that will be one of the factors you would look at when you're, that will affect the damage. So these are some of the things, and it makes sense. If you look at if it's stronger the current, greater the damage, longer the contact, greater the damage. So it makes sense. So what are some of the mechanisms of injury from electrical shocks? Now, one is where there's direct effect of the current on the cells and tissues. So this is where you can have direct when you get the burn to directly to the tissue, where at the site of entry, at the site of exit. The next is conversion of electrical energy to heat energy. So this is thermal damage that you can have to the internal organs. You can have electrical current mediated muscle contractions. So this is where sometimes you have these patients that come in with opisthotonus, where they have this tetany or things like that. That's because of the muscle contractions that are induced by these high currents. And then based on, remember we said the extent of damage is based on the voltage of the current. So low voltage is usually what you would see in general office, household. Usually, Canada, US is not that different. So 110 to 240 volts. And then Europe is up to 4, because it depends on, it's not just the voltage, it also depends what kind of current. So if it's an AC versus a DC current, which one do you think is worse, AC or DC, when it comes to the extent of damage? Direct current is safer. And why is that? You're right. Huh?
Right? It's like when they tested direct melting, they like.
So the direct current, it's brief. It essentially causes like single muscle contractions. So it's brief. So that's why once they get the current, the patient is actually essentially they're thrown away from the electrical stimulus. So they can lose that contact easily after that initial current. With AC, it's a prolonged state. So it essentially holds on to it pulls the patient closer to the electrical stimulus. So that's why they maintain that contact for a longer period of time. So that's why AC is actually, you can get, if you're just comparing AC versus DC, AC is actually the one that causes worse damage. So, and then obviously when it comes to lightning, these are billions of joules of energy that's created. And we'll talk about this when we talk about lightning injuries. I've never seen one. You might see some, I think, if you're in the ER setting or if you're in an area where lightning hits frequently, you might see some, but it's rare, but happens. Okay, so when you think about electrical injuries, there's a concept of let-go current. So essentially, this is the ampere. This is the current, the I that we looked at in the Ohm's law. This is the amperage at which the human body can actually withdraw from the electrical stimulus. So if the electrical stimulus is much higher than that amperage, you would essentially, the human body cannot withdraw from the stimulus, and then you start seeing all these consequences where you have respiratory arrest, you have cardiac arrest, you have tetany, VFib, things like that. So that's where and nobody knows exactly what this let-go voltage or let-go amperage is. It's different for different people. There's no set value for it. And then one thing to remember is low voltage does not mean low hazard, right? So you also have to look at the type of current. So like we talked about AC, DC. So you can have AC low voltage and a DC high voltage. The AC low voltage might actually be more deleterious. So low voltage does not mean low hazard. So some of the implications from electrical injuries having various effects on the body. One is the cardiac. When it comes to cardiac effects, the incidence is based on the literature, anywhere between 4 to 17%. A lot of times these arrhythmias are usually benign. Practically you can see anything on the EKG. You can have ST changes, you can have QT prolongation, you can have AV blocks, you can have new bundle branch blocks. Practically you can see any change on EKG secondary to this electrical stimulus. However, when you think about the fatal or the more malignant arrhythmias, you think about VFib. This usually occurs more commonly with AC exposures or low DC voltages. Usually if it's high DC voltage, or when you think about lightning, asystole is what a lot of times you'll see in these high-risk arrhythmias. So some of the respiratory effects, again, like I mentioned before, you can have tetany, just like you have tetany of other muscles of the body, you can have tetany of your respiratory muscles, including your intercostal muscles, your accessory muscles, that can cause respiratory arrest. You can have autonomic nerve dysfunction that can paralyze or cause impairment of your diaphragmatic movement. So you can have autonomic nerve dysfunction. You can have blunt chest trauma itself, where just by the sheer force of, say, so where, just say if the patient was thrown away from, it was a DC current, the patient was thrown away, fell off a lot, you can have like blunt chest traumas because of this. So these are some things you might want to keep in mind. And then neurological, usually, you can have central nervous versus peripheral nervous system, and usually at high voltages, you would see more central effects. So altered sensorium, coma, spinal cord damage, and then peripheral, usually with low voltages. And this is where you would see injuries to your nerve plexuses, to paresthesias. It can be as, trivial as just like tingling. So those are with low voltage injuries. Some of the orthopedic effects, a lot of them these get assessed for in the ER, but things you might want to keep in mind is a lot of times you would see with orthopedic, especially high voltages, you can have like posterior dislocation of a lot of your joints, which we don't, but it takes a lot of force to do that. You can have rhabdomyolysis, compartment syndrome in these patients. And then obviously you want to assess for burns at the site of entry and exit. And then with the rhabdo and compartment syndrome, especially with the rhabdomyolysis, you want to evaluate for kidney dysfunction, renal dysfunction, and AKI. And then one thing to keep in mind, it's mostly with lightning injuries, is these patients make sure with lightning injuries, it's a little bit different, where in their initial evaluation, you need to have ophthalmologic evaluation done as part of the initial evaluation, because these patients can have corneal burns, and they're at high risk for ocular cataracts from lightning, as high as like 6%. And then in those cases, you also, a lot of the times with lightning, the entry of the current is actually through the ear. So any orifice in the body can be a source of entry. So a lot of times it's the ear. So you want to assess them for perforated tympanic membranes, cochlear damage, and things like that. Okay, management. So first scenario, so you have a patient who had an electrical shock. It was a low voltage shock. Patient is awake, denies any major symptoms. What are you going to do? Would you, sorry, ABC. Okay, yeah, so patient's talking, walking, vitals are fine. Yeah, you would evaluate this site. Yeah, they have like no complaints. Do you need an EKG?
Yeah, I think so. Like, somebody shocked us.
Actually,
Like, no.
I'm trying to give away the answer, but actually you don't need to do anything. So if they're not complaining of any symptoms, if it was a low voltage shock, if you for sure know it's a low voltage shock, you actually don't need to do anything. You can discharge them home. You don't even need an EKG. You don't need a urine study, CPK, none of that.
How would I know if a low voltage shock?
They would tell you, right? Like if it was at home or was it at, a lot of times, like if it's an industrial shock, there's probably high voltage. If it's household or, obviously if there's certain machinery that we're operating, you might want to ask, like, if the patient's awake or, if they know what the voltage was. But usually if it's household or, basic office, these are usually low voltages. You'd actually discharge them. You don't necessarily need an EKG on these patients. I thought you would need one too, but essentially if they're not complaining of any symptoms, you don't need it. So now look at this patient. It's a patient who had a low voltage shock, but now the patient is a little confused. And and the EKG shows mild QT prolongation. So in these cases, you want to investigate further. So these are the patients you don't want to discharge right away. You probably want to observe them at least for 12 hours under observation, and then maybe admit them based on what their labs are. These are the patients you want to do a thorough investigation on. So some of the red flags that you would look for when you're thinking about triaging this patient, whether they should be admitted, they should be discharged. Things to look for is chest pain, palpitations, any altered sensorium, loss of consciousness, confusion, any weakness, any shortness of breath. Obviously, if they have burns, any vascular compromise, if they're hypotensive, which is self-explanatory, you won't be sending them. And then if they have any EKG changes, you don't want to discharge these patients preemptively. You probably want to watch them at least for 12 hours or more before you decide to send them home. Now, this is a patient who endured a high voltage injury with severe burns, and then the patient's admitted in the ICU, and the nurse tells you the lower extremity compartments are rigid, the thigh is rigid, the calf is rigid, the pulses are hard to palpate, and the Foley is now draining dark urine. I heard a few different thoughts. Yeah. So what are you worried about here? Compartment syndrome, right? So obviously, so a few things. So one is if this patient's urine output's dropping, if the patient, what other thing? Compartment syndrome, and if the urine's turning dark, urine output's dropping, rhabdo, right? So these patients might be, if the patient has severe burns, one other thing you would essentially worry about in this patient is like any hypotension, right? So that means they've lost quite a bit of fluid. So they have a lot of insensible losses. And actually electrical injuries, I don't know if you guys remember when Jess did the burns and she talked about the Parkland formula to figure out the fluid resuscitation. These patients actually, there's no clear-cut evidence, but based on expert opinion, they actually recommend their fluid requirements are actually a little bit higher than what you would get from Parkland formula or modified Parkland formula. So these are the patients where you want to give them a little bit more fluid. And then usually you would titrate fluids to, where their urine output is at least 100 cc's or above per hour. So that's how much fluid you need to give these patients. With burns, you always want to evaluate this patient to see if they can be transferred to a burn center. For us, it's DMC, that's where the burn center is. So, if you see somebody with severe burns, don't wait on them. If they're stable enough for transfer them to a burn center for, burn-related care. And then obviously these patients you want to evaluate periodically. So your neurovascular checks in these patients in the ICU is going to be critical to evaluate for compartment syndromes. And then obviously if there's any concern, get our surgical colleagues on board. And then obviously if with AKI, at this point, everybody knows how to manage rhabdomyolysis and, based on the patient situation, fluids, diuretics, wherever. Be careful with diuretics, at least in the initial phases, because these patients are still fluid down. So be careful with the use of diuretics. I'm just going to talk briefly about lightning injury. So this is essentially, it's rare. We don't see it that often. The mechanism of injury is either through direct contact, where it's the deadliest form of injury. If the lightning hits you directly, God help you. But essentially, it's rare, but it happens. Contact injury is where essentially the victim or the patient is touching certain things that was hit by lightning, be it car or any metal objects which conducted the electricity. You can have side flash, where the energy from the strike itself is diverted to the patient who happens to be in the vicinity. And then step voltage is blunt trauma. We all know what that is. Step voltage is essentially, right. You see it? So essentially where you're not touching anything, but the electricity gets It's the bottom figure there, the bottom left, where essentially it gets conducted to the ground and hits the person. Huh? Oh, so these are different mechanisms.
Oh, I missed it.
So yeah, we don't see that often, but I thought it was okay. So like I said, I just didn't know how to make it more interesting, so I put memes there. But yeah, so things like I said, you want to look for in these patients is ophthalmology evaluation, ENT evaluation, and then if these patients are hypotensive, be mindful that they, from the trauma, blunt trauma itself, they might have had internal bleeding, and so look for, make sure you evaluate for that if you see any signs of hypotension. And I think we are out of time, right? Yeah. So I was just going to brief it, but this is, I think Jess covered a lot of it in her lecture, but essentially it's just inhalation, but the slides will be there so you guys can take a look at it. And there are several other environmental injuries that I came across and I didn't have time to go over, but these, if you end up in Arizona, or where there's snakes or poisonous spiders, these are things you have to worry about. Okay, and any questions?
About the elephant, because like, I think it's like Thomas Edison was trying to convert America that DC was safer than AC. They brought an elephant over to show that they could touch his current and not, oh no, they touched the AC and the elephant would die, or it's so bad it can kill an elephant that big. It's like, it was like in trying to get it over and make test that. Right? Yeah. For business to like get people to buy his current.
Yeah. It was interesting. Do you guys know why like birds, when they sit on the live wires, they don't get electrocuted? They're not, yeah, you need like you need entry, yeah, you need 2 point of contact, so yeah. Okay, thank you.